All right, if you're currently deep in revision for your A-level history exams, specifically Topic 2B on British public health from 1918 to 1979, you are in exactly the right place. We're going to use this explainer to unpack the monumental triumphs, as well as the very real shortcomings of healthcare during this fascinating era. We'll break down the facts, the statistics, and the major historical shifts, so by the end of this, you'll be fully prepared to tackle those tough exam questions. Let's dive in. So here's the ultimate essay problem I want you to keep in the back of your mind as we go through this. Was British healthcare truly revolutionized by 1979? Or were the profound class divides of the 1920s and 30s simply masked by a new centralized system? Did class inequalities just get a new name? This is the absolute core debate you're going to need to argue. To give you a clear mental map for your revision, we'll follow a sort of problem-solution complication arc across 6 distinct sections. We'll cover the pre-war patchwork, WWI and the blueprint, building the NHS, society and class, medical advances, and finally, the 1970s funding crisis. Okay, starting with Section 1, pre-war patchwork. Let's look at the baseline of healthcare in 1918. So at our 1918 baseline, the government actually did provide compulsory national health insurance, but it was incredibly limited. It only covered low-paid wage earners making under £160 a year. That meant their families, wives, children, and the unemployed were left totally unprotected by the state. The care available to the poorest was, frankly, grim. You had poor law hospitals, which were often just converted workhouses that effectively acted as prisons for the destitute. On the flip side of this messy patchwork were the voluntary hospitals. These were charitable, university, specialist, and smaller cottage hospitals that relied entirely on donations and the goodwill of unpaid doctors. Basically, getting good healthcare was an absolute lottery of geography and wealth. Now grab your pens because here is a shocking statistic that is crucial for your continuity versus change essays. During the Great Depression of the 1930s, working-class men lived on average 12 years less than middle-class men. 12 years. Plus, middle-class women were 50% more likely to survive childbirth than working-class women, and overall mortality rates in deprived areas were up to 50% higher. This single number really hits the nail on the head about how lethal health inequality was before a national system existed. But there were some early glimmers of consensus. For instance, in 1919, the government created a new Ministry of Health to coordinate regional care and tackle rampant diseases like tuberculosis. Take a look at the 1938 Finsbury Health Center in Peckham. This was a futuristic, highly influential, high-tech experiment in preventative health, addressing hygiene and TB head-on. It literally had a swimming pool. Facilities like this directly inspired the wartime planners who would eventually design the NHS. Moving on to Section 2, World War II and the Blueprint. The horrific threat of German air raids acted as a sudden, massive catalyst for radical change. Anticipating millions of casualties, the government set up the Emergency Medical Service, or EMS, in 1939. This forced a nationwide pooling of resources, skills, and expertise. For the very first time, the government was dictating hospital activities, and most importantly, it proved to hesitant doctors, specifically the British Medical Association, or BMA, that a national, state-run framework wasn't just highly effective, it was actually financially attractive. The blueprint was drawn. Which brings us nicely to Section 3, Building the NHS, the famous 1946 Act. Forged out of the 1945 political consensus, Labour's Aneurin Bevan spearheaded the monumental 1946 National Health Service Act. Okay, you absolutely must drill these 3 foundational principles into your memory for any essay on the NHS. Bevan insisted the system be universal, meaning for absolutely everyone. It had to be comprehensive, covering mental and physical health, curative and preventative care, plus opticians and dentists. And, revolutionary for the time, it had to be free at the point of delivery, funded collectively by direct taxation rather than individual insurance policies. Actually executing those principles, however, was incredibly messy. Under the early, highly complex 3-tier structure of the NHS, hospital services were run by independent boards, while community services like ambulances and vaccinations were managed by local authorities. But here's the real complication. Primary care, your GPs and dentists, remained independent businesses. Because GPs were still private businesses, the BMA heavily opposed building centralized health clinics, terrified doctors would lose their independent income. In fact, by 1958, only 10 of these planned clinics had actually been built. That takes us straight into Section 4, Society and Class, the lingering inequalities. So, did the NHS actually cure deep-rooted societal inequality by 1979? A fascinating concept to use here is the inverse care law, a theory formulated in 1970 by researcher Julian Tudor Hart. He argued that there's actually an inverse relationship between medical need and the availability of treatment. Those who needed it most were the least likely to get it. Hart compared middle-class areas of London, which had wide availability of care, to deprived Welsh mining communities. In Wales, the medical needs were serious and frequent, yet they had relatively few medical professionals. Researchers also noted that articulate, middle-class patients simply knew how to work the system better to get more out of it than working-class groups. We also see massive class divides when we look at medical advances like the 1967 Abortion Act. While it gave women reproductive rights on paper, the reality depended on the approval of two, typically male doctors, who were prone to stereotyping working-class women. An astonishing 88% of abortions were performed in the private sector. This meant the procedure was easily available to middle-class women who could afford the hefty £200 fee, while working-class women were often left at the mercy of the NHS system's moral judgments. Deep complications were also present in mental health provision. By 1957, investigations revealed patients were being treated inhumanely in hospitals that essentially operated like prisons. So the 1959 Mental Health Act attempted to modernize this. It changed the language from insane to mentally ill, removed judges from the forced treatment process, and introduced an open-door policy. The goal was to shift away from residential lockups and move toward outpatient daycare. But unfortunately, the reality of that reform was terribly grim. The government simply didn't fund the necessary community centers. By 1979, only 15% of the needed daycare places were actually available. The system was utterly failing its most vulnerable patients, leading to 25 separate inquiries into psychiatric hospital abuse and misconduct between 1967 and 1981 alone. Let's look at Section 5, Medical Advances, and how the NHS became a victim of its own success. See, rapid scientific progress became a massive financial double-edged sword. Tracing the timeline from basic vaccines in the late 40s to highly complex procedures, the demand skyrocketed. By the 1960s, the UK had a rapidly aging population, growing from 7 million people of retirement age in 1951 to 9 million by 1971. Because people were living longer, the demand for high-tech, expensive surgeries exploded. Think about this. In 1960, hip replacements were literally impossible. By 1979, the NHS performed 24,000 of them. This meant the number of technical staff needed to run dialysis machines and assist in organ transplants ballooned from 407,000 to over 1 million. The costs were absolutely staggering. And of course, medical advances aren't just expensive. Sometimes they go horribly wrong. Tragedy struck with thalidomide. This was a drug developed in West Germany, successfully relaunched to prevent morning sickness in pregnant women. But it resulted in 10,000 seriously deformed babies worldwide. It perfectly and tragically illustrates the profound risks associated with the rapid expansion of new medical treatments during this era. Finally, we reach Section 6, the 1970s funding crisis, and the breakdown of the post-war consensus. Up until the 70s, it was kind of taken for granted that continuous economic growth would just easily fund the ever-increasing costs of the NHS. But then, severe economic chaos hit. Make sure you trace this domino effect in your notes. Throughout the 70s, spiraling inflation meant real wages fell. In response, a new economic theory called monetarism took hold among conservatives, arguing that excessive state welfare spending was actually the root cause of the inflation. The crisis peaked in 1976 when the government was forced to take a massive $4 billion loan from the IMF. The condition? The IMF forced the government to implement £2.5 billion in immediate cuts. While pensions were protected, the economic confidence that had endlessly funded the NHS was completely shattered. So as we wrap up our revision of Topic 2B, I want to leave you with this final provocative thought for your exam essays. Did the NHS actually fail by 1979 because it couldn't solve class inequality, or did it just become far too successful for the crumbling 1970s economy to afford? It's a massive tension between incredible medical progress and harsh economic reality. Good luck with your revision, and keep thinking critically about these big historical shifts.